extend a very special welcome and special thank you to Doctors Hamadi and Ramos from Honor Community Health, who are here to give us some factual information related to the COVID-19 vaccine. So with no further ado, I'm going to go ahead and turn it over to Dr. Hamadi to kick us off.
Thank you, Dr. Lawson. Thank you again for having us. We appreciate the confidence that you and your team has in us in presenting data that we believe is factual, that is evidence-based. Decisions are often made on perceptions, based on perceptions, but we want our information that we present to you to be very factual, very data-driven. So I'm going to introduce my colleague, Dr. Jason Ramos. Dr. Ramos is a board-certified family physician. He has been with Honor Community Health now for almost 4 years. He will also be joined by another one of our colleagues, Dr. Latoya Austin. Dr. Austin has also been with Honor Community Health for about the same period of time. And again, we've done our homework. We've been tracking the vaccine for the past several months. We're very excited to be here in front of you, presenting data that is very factual. So thank you, Jason. Please go ahead.
All right. Thank you, Dr. Hamadi. And thank you, everyone, for attending and giving us a chance to share information about the COVID-19 vaccine. So, all right. So I will use your help to advance the slides. That seemed to work last time pretty well. So, all right, you can go to the next slide. Yes. So this is the outline of the talk. So first, we want to go over, why we're having this discussion and why it's of great importance right now. You just wanted to give a word on the timeline of the vaccine rollout and when we can expect to have the vaccines available. Then the next two bullet points are really important ones. We want to go over the vaccines. Are they safe and are they effective? And then also some concerns that have been voiced by various folks, and so that we can address them. And then we kind of want to end with, just going over the overall goal. Of course, all of us want to have COVID-19 behind us. And we want to go over, what that will take and how that might look like. And then I always end the talk with some 5 take-home points, and then we can have a discussion after that. All right, so next slide. So the reason for the discussion. So I've given this presentation a couple of times now, and each time I'm updating the numbers, and it really just kind of drives home, how significant the pandemic is right now. So as of December 15, yesterday, there were almost 73 million cases worldwide and 1.62 million deaths. And so in the United States, 16.1 million cases. And I updated this just early yesterday. It was 298,000 deaths, but now I see we're up above 304,000 deaths and about 2,500 deaths per day, unfortunately. So it is a raging pandemic, and that's part of the reason why we're giving the talk today. Next slide. All right, so this just basically shows in graphic form what we were just talking about. You see the daily cases and the 7-day average. This was done or updated yesterday. So you see those numbers with the red dots, those are single-day records. So the 7-day average of daily cases in the United States is just over 200,000. The 7-day average of those hospitalized were over 107,000. And then the deaths, as we see, 7-day average is approaching 2,500 a day. Next slide. Okay. So this is a snapshot of the Oakland County dashboard on COVID-19. You can access this yourself also. This is updated daily. And so this is a snapshot for Oakland County. So you see in the top left corner, approaching 50,000 cases. And then in the top right corner, you see the number of cases per day. The 7-day average cases actually in the county, if you look at the graph on the left lower corner, seems to be actually encouraging a little bit. But we know, we've seen in the last 9 months how this has gone and has had multiple spikes. We're still worried about a potential spike after the holidays, after everyone, hopefully not too many, but after many people congregate for Christmas and New Year's and the rest of the holidays. So next slide. So the other big reason why we're having the discussion is because now Michigan, along with the rest of the US, started immunizing individuals in group 1A, and we can go over what that means in a bit, but it started immunizing individuals this week. Next slide. So this was the snapshot from last week, Thursday, the New York Times article talking about the FDA authorizing the emergency use authorization for the Pfizer vaccine. And we expect the Moderna vaccine will get this approval as soon as this week, actually. Next. Let's see. Okay. So group 1A, that includes hospitals, health systems, and health centers, and also residents of long-term care facilities. This is the first group to have access to the vaccine. And, getting a count of those who are wanting the vaccine within this group 1A definitely helps the planning, the logistics, and attaining and distributing the vaccine. Next. So we wanted to help all of those who are eligible, especially in that first group in 1A, to get the vaccine, to have their questions answered, have concerns addressed related to the vaccine. And we wanted to help enable everyone to make informed and comfortable decisions regarding that, and wanted people to be able to avoid just gut decisions based on whims and misinformation. We didn't want people just rejecting the vaccine just because they have a gut feeling about it, but also didn't want people just taking the vaccine with the same gut decision without understanding why it's actually recommended. Next slide. So just a word on the timeline. Okay, so yes, we are here at December 16, and then this is our week that we're in, is that purple box there, and we started giving the vaccine at various hospitals earlier this week. The 2 weeks highlighted in blue underneath that is when we think that health centers, outpatient health centers like ours, will be able to get access to the vaccine and start immunizing our first group of people in 1A. And next slide. So this is just a graphic. This is one of the 2 vaccines, and this is how the Pfizer vaccine is packaged and stored. 1 vial contains 5 doses, and that tray that you see there holds just under 1,000 doses. That's all stored at super cold temperatures, -70. You'll see that slide again a little bit later. So next slide. So for our outpatient site, our vaccine hub will be Hamilton Health Network in Flint. That's where the deep freezer will be for the initial shipments of the vaccine. Once the vaccines are removed from the deep freezer, then it can be refrigerated for up to 5 days if it's the Pfizer vaccine. If it is the Moderna vaccine, it is about a month. So next slide. So here we'll go into a little more detail on the vaccines. Like I said, this bullet point and the next one are the kind of gist of the presentation. So the vaccines, are they safe and are they effective? So I've made reference to those two vaccines. There's a vaccine A and vaccine B. And vaccine A is made by Pfizer. Vaccine B is made by Moderna. And these are the first vaccines that work on the basis of mRNA or messenger RNA. They are not live COVID-19 virus or weakened or dead versions of COVID-19 that you're getting injected with. These are just a snippet of the virus's genetic code that code for a certain part of the virus. And there's a couple of graphics that are later in the presentation shown a couple of times just to kind of make that clear. And it basically teaches your immune system to recognize those proteins. So next slide will show what we're talking about. So I think we've all seen this graphic of the COVID-19 virus. Those red proteins, those red things that look like spikes, they're actually called the spike proteins. And they are not what makes you sick. They are what the virus uses to attach to our cells. And then from there, the virus can have its genetic code enter into our cells and make us sick. But the spike proteins themselves don't make us sick. And that's the target of these mRNA vaccines. More on that later. So next slide. So vaccine. So again, there's two vaccines, Pfizer and Moderna. We'll go into those now. So the Pfizer vaccine, as we talked about, needs to be stored at -70 degrees. Once it's removed from the freezer, it can be refrigerated for up to 5 days. There's 5 doses per vial. And once you reconstitute the vaccine in each vial, then you have 6 hours to administer those 5 doses in the vial. So all of that affects logistics and planning. There's the slide again. Go to the next. The Moderna vaccine is a little easier to handle logistically. It needs to be stored only at -20 degrees. And again, once it's removed from the freezer, it can be refrigerated for a month. So both of these vaccines have been shown to be about 95% effective. So the Pfizer vaccine is 95% effective about 7 days after the booster. And the booster for the Pfizer vaccine happens at day 21. So you get a shot on the first day, and then 21 days later, you get the second dose, and then you're done. So the biggest trial, it was a phase 2, phase 3 trial for this Pfizer vaccine, had over 40,000 subjects. Half of the 40,000 received the vaccine, and the other half received an injection of just a placebo. And none of the subjects knew what they got, the vaccine or the placebo. Next slide. The 40,000 or so people were diverse in age, gender, ethnicity, and race. And they followed those 40,000. Of those, 170 people got COVID. And of those 170 people who got COVID, they found 162 of them had received the placebo, and only 8 had gotten the vaccine and still gotten COVID. Next slide. So Moderna is almost 95% effective, and that's 94.5% effective 14 days after the booster, and that booster is given at day 28. The largest phase 2, phase 3 trial for Moderna was about 30,000 folks. And again, they were diverse in, in age, gender, ethnicity, and race. Half of the folks got the vaccine, half got placebo. They followed those folks, and 95 people contracted COVID. And of those 95 people, 90 of them had gotten the placebo, and only 5 had gotten the vaccine and still gotten COVID. Next slide. So to kind of put that in perspective or have that kind of make sense in numbers to us. So what would it look like from day one if we had had a 95% effective vaccine at the start of this pandemic? As we stated earlier, the US has about 16.1 million cases right now. And so if we say we had, say everyone had that vaccine, only 5% of those would have still gotten COVID. So that would have been 805,000 cases instead of 16.1 million cases. And if we say, next slide, that the mortality rate for COVID is about 2%. So 2% of 805,000 is about 16,100 COVID deaths. And we are looking at, now I told you this is outdated already from yesterday. We're over 304,000 deaths. So it kind of lets us know what the next 9 months, 8-9 months could look like. Hopefully it looks something closer to 16,000, even that is a lot, but hopefully it looks like a far cry from another 300,000 Americans dead. Next slide. So the safety of the vaccines. So Pfizer did meet all of the FDA and emergency use authorization safety milestones, and there were no serious safety concerns. Adverse events are graded as grade 1, 2, or 3. 1 and 2 are mild or moderate, respectively, and grade 3 are called severe adverse events reported by the subjects. So were there any grade 3 or severe adverse events that occurred at least 2% of the time? Yes, there were. And next slide shows fatigue in about 3.8%. So severe fatigue in about 3.8% of folks who got the vaccine, and 2% had severe headache. These were usually after the second dose and typically were self-resolved or were self-limited, I should say, and lasted about 24 to 48 hours. Moderna also met all the FDA and EUA safety milestones. There were also no serious safety concerns. Were there any grade 3 adverse events that occurred at least 2% of the time here? Yes, there were. And it's on the next slide. So fatigue in just under 10% of people, headache in about 9%, some joint pains in 5%, pain and redness in about 4 and 2%. And again, these were typically after the second dose, and again, resolved after 24, 48 hours. So you see the vast majority, 90% of folks will not have any severe fatigue. And on down the list you see there. So these side effects, they were milder and less frequent in those over 55. So that was a good thing to know. So concerns about the vaccine. So we hear about the concern about the newness of these vaccines. Not just the vaccines themselves are new, but the basis of the vaccines based on mRNA, as these are the first mRNA vaccines developed. So it's important to know that harnessing mRNA to kind of develop certain proteins like those spike proteins is not a new technology. It's been studied since the 90s. We know that there are mRNA-based vaccines that have been studied or currently being studied for a few years now against all types of illnesses, rabies, HIV, pancreatic cancer, other types of cancer. So it's not a brand new technology. Next slide. So yes, these are things we talked about just now. I had heard from some staff about like long-term, have mRNA vaccines been studied long-term to see for any, to observe for any adverse events? Because, we know that these have been very safe, for 2, 3, 6 months. So this is an article from last year. This is not about the COVID-19 vaccine, but other mRNA vaccines, like I mentioned, that have been devised for other things. And so in those studies, which have been for longer periods of times, years, those have been shown to be safe and have no real severe long-term concerns. So the next couple slides are from this article as well, in Frontiers in Immunology. All right, so again, the basis of the mRNA vaccine is really focused on those red spike proteins. So next slide. So this is a graphic just to kind of demonstrate. So you see at the top of the screen, that's the vaccine. And at the bottom left of the screen, there's a picture of the virus. So you're not getting injected with COVID-19 virus. Right up at the top of the screen, next to the syringes, you see the red squiggly line. That's like the snippet of the COVID-19 genetic code that codes just for those spike proteins, not what makes you sick, but just for those like attachment proteins, if you will. So that is incorporated and it triggers our cells to actually make proteins that are very similar to those spike proteins. And so then our body recognizes that those spike proteins are not native to the body and forms immunity, forms antibodies to those. So later, if you become infected or encounter the COVID virus with those spike proteins, then your body recognizes those spike proteins and then kills the virus or produces antibodies to block those spike proteins so that they cannot attach. So that's the gist of that and the graphic that goes along. So another concern, the speed of the vaccine developed. This was developed so quickly, they must have skipped steps. So just so you know, the skips were not actually skipped. The steps were not actually skipped. So usually, if you go to the next slide, when the development of vaccines, yeah, there should be a graph. Yep. So you have phase 1, phase 2, and then phase 3 trials. Phase 1 is a very small group of healthy volunteers, 20 to 100, and then several hundred volunteers in phase 2, and then hundreds or thousands of volunteers in phase 3. And typically, phase 2 does not start until phase 1 has completely ended, and phase 3 doesn't start until phase 2 has been completed as well. What happened here in the setting of this raging pandemic is, next slide, is the middle graphic there in blue. So some of these phases and the large scale production of the vaccines were happening simultaneously. So you see the top graphic shows it in the linear, that's the linear process. But in the middle, you see that phase 2 and phase 3 were being done at the same time. Large scale production was starting before the completion of phase 2 and phase 3, with the intent that they would not, of course, distribute it or use the vaccine that were being produced in large scale if phase 2 and phase 3 did not show that the vaccine was either safe or effective. So overlapping those steps sped up the process. A couple other things also led to the speed of the vaccine. And so that's in the next slide. Next. So the worldwide community knew the genetic code of COVID-19 late in 2019 when the scientists in China saw what this was doing in Wuhan and released that genetic code to the worldwide community so they could get on it and research it and try to develop treatments and vaccines. So that they didn't have to start from scratch to try to figure out the genetic code of this virus in March. Next. So the concept of targeting that spike protein for a vaccine, that was already known from the SARS outbreak back in 2003. So it wasn't like a brand new mechanism that they had to come up with. So they already knew how to do that and that they need to target that. Next. We know that mRNA vaccines require less preparation time. They don't have to grow certain vaccine components in chicken eggs. So that speeds up the process as well. And next. And again, so as we talked about, multiple phases were done simultaneously along with mass production. And of course, we know the resources poured into this effort were, you know, of a scale unlike other vaccines being developed just because of the raging pandemic. What else? So how about, I don't think I'm susceptible. So I've had some staff say that, you know, they've had family members at home who've gotten it and they're not wearing masks at home and they ended up not getting it. So they don't think that they can get COVID in the community when they're wearing masks or when patients are wearing masks as well. So, so we know that that does not guarantee us not getting COVID. I think there's a lot still to learn about what or why we contract COVID in different settings, maybe dose related and other things. So we just can't know that if you're not susceptible. Another concern, is this a live virus? Am I getting injected with COVID-19? So nope, we are not. And hopefully the graphics before have made that pretty clear. Yep, and there's our graphic again. Next slide. So could I be infectious to others because I got the vaccine? That was another concern or question brought up a couple of times. So as you know, because you're not getting injected with the actual virus, you would not be infectious because you got the vaccine. So I added this since the last time. So there are other concerns. We know that there is some skepticism in some ethnic minorities regarding healthcare in general and the vaccine specifically. We know that Black and Brown population in the United States have been disproportionately hit and killed by COVID-19. And the same population has traditionally, or some people in the same population have traditionally had skepticism regarding healthcare. And the skepticism is not entirely unfounded. We know that there's been some ugly moments in medical history with unethical, research and vaccination, unethical studies regarding treatments of certain conditions. So I was actually encouraged, next slide. Next slide. I was actually encouraged when I was reading ACIP. If we could move on to the next. Just want to make sure can you advance that? Back one more, please. Oh, okay. So yeah, the ACIP, Advisory Committee on Immunization Practices. So it was encouraging to know that from the outset, when they were planning the distribution of this vaccine, two things were among their guiding principles. And if you go to the next slide, you'll see promoting justice and mitigating health inequities. So, it's not a situation where just those with means or the wealthy will get first dibs on the vaccine and everyone else is in line. There's actually a recognition that there are these health inequities and that COVID has disproportionately hit certain populations. So we have work to do to get that message out that this is not something that's just going to affluent people. And on the flip side, it's also not something that's just going to experiment on poorer folks or certain ethnic backgrounds or races. Quite the contrary, actually, the ACIP has really pointed out their recognition that there are health inequities, and they want to help get the vaccine to those who are disproportionately hit and who are at most risk. Yep, next slide. So what is the goal? So the last few slides here really kind of point out the goal of really COVID-19 fizzling out. We want to get this behind us and that will require herd immunity. So many of you probably know what herd immunity is, but I think it's always important or helpful to, visualize it. So the next couple slides show that. And can we get to the next? Mine is not advancing. Okay, yes. So here you see at the top of the screen, 3 types of people. And then at the bottom of the screen, 3 scenarios. So the first scenario, type of person is that blue person who's still healthy but not immune to COVID. The yellow person is immunized and healthy, and the red person is someone sick and contagious with COVID. In the far left situation, you have a couple people with COVID in the community with a bunch of people who are not immune. And then you see the result at the bottom left. So all those previously healthy folks who were not immunized and who are vulnerable are now sick. And that can overwhelm hospitals. That's what leads to really the high death rates we're seeing. In the middle, you see a smattering of people, a person here or there who might have gotten the vaccine, among a lot of people who are healthy but not immune. And you still have the same 2 people with COVID. And the result is down there in the middle bottom section. The vast majority of folks still get sick, and that still can overwhelm hospitals. We really want to get to the situation on the right where the vast majority of people are immune, so that you still have, if you still have vulnerable folks like those 4 blue people in the top right corner, enough people in between this enough people are immune in between that vulnerable person and the sick contacts that not many of them will get it. And that's the result in the bottom right corner. That's where we want to get to. The next slide shows pretty much the same thing. The red dot is someone with COVID. The yellow dots are people who are vulnerable and who have not gotten the vaccine or who are not immune. And the green dots are those who are immune. And so you see the person with COVID, enough people are around that person who are immune that it's not spreading to those vulnerable folks or yellow dots. So next slide. So the question always is, so how many green dots do there have to be? How many people do you have to get vaccinated to achieve herd immunity? And so we think it's around 70% of people need to get vaccinated or need to be immune for that situation to happen. And so what if we were to try to get herd immunity just by letting it spread without a vaccine? So those people who, everyone just get it. The people who die, and the people who live, now they're immune. So if you wanted to do it that way, to get to 60% of herd immunity, that's what it would look like, 1.2 million people dead in the United States. We're just over 300,000 now. So almost another million dead. So hopefully we try to do it with a vaccine instead. Next slide. So other positives from getting the vaccine, we could more safely visit parents or grandparents or other vulnerable family or friends, knowing that we're not gonna spread it to them. Less likely to miss work while you're awaiting test results after an exposure. That's been happening very frequently at our workplace. You're also less likely that maybe a household member will need to wait for test results because they've been exposed to you, who may have come into contact with positive patients. Next. You're less likely to contract COVID from kids who might be doing face-to-face schools, or when that resumes, they're less likely to bring it home to you. Next slide. Again, schools and businesses can really safely reopen when herd immunity is reached. Next slide. Okay, so just a slide on facts and or myths regarding COVID-19. Next. So a vaccine will give me COVID-19. I think you understand now that you won't get it. The mRNA vaccine alters my DNA. So that does not happen. Remember our slide? Yep, you can go to that slide. The next, so it's not going into the nucleus where our DNA is made. It will not affect your DNA. Next. And the flu vaccine will protect me from COVID-19 as well. That's not true. And I've already gotten COVID-19, so the vaccine won't do me any good. We do not know that. We think that, you know, we don't know how long your immunity is from after you've gotten COVID-19. Early studies show it may not be that long, maybe just a few months. So yes, the take-home points. COVID-19 vaccine is now available to people in Group 1A. Want you to make your informed decision based on facts instead of just gut feelings or fears of the vaccine. The development of the vaccine has not skipped any safety steps. And both vaccines A and B have been shown to be safe and effective. And ending the pandemic and all of its impact, health, financial, scholastic, and social, will likely require 70% of the population to be immune to the virus. All right, and with that, that is what I had. I think I see a lot in the chat box with questions.
Yeah. So we're open to take questions. So we're also joined by Dr. Austin, who will also participate in our panel to answer questions. Thanks, Dr. Ramos.
So the first question we had was pertaining to allergies to vaccines, and if people have allergies or have had adverse effects to other vaccines, is this something they should consider doing or not?
Dr. Ramos?
Yeah. So that question really came to the fore in that first week with the Pfizer vaccine. And, there were 2 cases of anaphylactic reaction and 1 other allergic reaction. So the recommendation at this point has been if you've had an actual anaphylactic reaction in the past to medications, and I think food is, if I'm not mistaken, then it's not recommended to get the vaccine until we get further information. Regular allergic reactions, as I understand it, Dr. Hamadi can correct me if I'm wrong, still would be fine.
So I think we will continue to get more data on the allergic reactions aspect of the vaccines probably over the next month or so. At present, it is recommended that individuals with severe allergies, either to medications or to vaccinations, not get the vaccine. That is, however, likely to change based on, like I said, data that we get from the vaccine manufacturers. I think it's important to know that the average rate of reaction, a severe reaction or an anaphylactic or a life-threatening reaction from a vaccine is 1.3 to every million doses. So it's very rare, but they're likely to happen. What do we do if we do have an allergic reaction, a severe allergic reaction, which could even happen in response to a flu vaccination? We're always prepared. We are always prepared to deal with a severe allergic reaction. For example, we have ordered about 200 doses of EpiPens or epinephrine pens at our locations in order to combat any potential adverse reaction that may occur in response to the COVID-19 vaccine. So allergic reactions can occur. They typically are very rare, but again, the data will tell us over the next month or so. We'll have additional information on that.
So the next question in the chat was regarding the vaccines being distributed in the United States, are they the same vaccines being distributed in other countries?
Yes.
Dr. Austin?
Yes. It is.
Okay. The next question was, how long will the vaccine last? Will it be like the flu shot where it has to be given each year?
So that's a good question. We don't know for certain how long the vaccine will last. We don't think, although we can't know for sure at this point, that you'll need it annually. There haven't been, certain mutations that similar to like the flu virus so far, but it's still relatively early. Very effective at 3-month mark, and what I read recently was almost certainly still effective 6 months out. But still, that is a question we are waiting to get more information on.
So that is one area that I think we are still continue to collect data, or the manufacturers are still collecting data on, is the long-term durability of the vaccine. As Dr. Ramos and Dr. Austin mentioned, how long does that immunity actually last for? We know after natural infection, it probably lasts for about 6 months, but the epidemic has been out only for about 9 months. So we know that it probably lasts for about that long. From a natural infection. The vaccine is probably around the same time. Right now, we are measuring immunity based on the antibody levels. But we feel that the vaccines and the virus is also inducing some other form of immunity in your body. And they are stimulating what are called the memory cells. The memory cells in your body are the T cells, and they're causing your T cells to remember that virus for a very long time. Think about it as a fragrance that you probably smelled 10 years ago. And you say, when you re-smell that, you say, geez, I remember this. I smelt this someplace. So that's the same memory that your cells have built in within them to remember the virus. So we feel that there is some other form of immunity that this virus and of course, hopefully the vaccine also induces, so that if your body is exposed to it 2 years from today, that it's likely to respond well. But that's more information on that to come.
So the next question is about how the vaccine is affecting people who have existing medical conditions, such as those who have cancer or an autoimmune disease. What types of medical issues did the participants have? This particular individual read an article where 5 people had Bell's palsy after using the vaccine. Is this something that any of you have heard?
Dr. Ramos, do you want to take that? Or Dr. Austin?
Oh.
Dr. Austin, you're on mute. Yeah.
Well, the participants were healthy individuals as well as patients who were considered to be immunocompromised but were stable. They had HIV patients whose viral load were undetectable, so they were stable. So we don't anticipate that someone who has lupus would have an adverse reaction to the vaccine.
No, I'm sorry.
Go ahead, Dr. Ramos.
Oh, yeah. No, that's right. I think that's exactly right. I did see some people who were actually on medications that were actively suppressing their immune system were excluded from the study. So I think there's more information needed on that.
So I just want to comment, make a comment on the question related to Bell's palsy. Bell's palsy is a unilateral facial paralysis that occurs. We see that in clinical practice. There were apparently 4 cases that were reported in the group that caught the COVID vaccine, the Pfizer COVID vaccine. From the information that we have presently, it appears that those cases were transient and the facial paralysis was mild. The company as well as FDA reports that, if you look at the general population, the number of cases that occur in the general population, this was in line with what the general population cases would be at. And so although it is a safety signal that comes from the vaccine, the FDA feels it is pretty much something that is in line with the general population. However, we will continue to monitor that particular data.
Thank you. So the next question is, in what order will other groups receive the vaccine following 1A?
So 1B group includes teachers, police officers. So there are typically in the first category, there's 1A, 1B, and 1C. So first line will be, long-term care facility, group homes, and healthcare providers. And secondary would be, teachers, police officers, and so forth. So general population would be somewhat later. We anticipate that to be sometime in maybe early spring, we're hoping.
Yep, that's right. And then group 1C is those over 65 and those with chronic conditions.
Thank you. So the next question is, if individuals receiving services through the public mental health system and staff are negative, but have been working with or have been exposed to a positive, an individual diagnosed as positive, is there a waiting period to get the virus?
So if you could repeat the last part of the question, please.
I think they're talking about if you were exposed, what is the duration on which you would contract the virus if you were exposed to it?
Oh, anywhere between the day after that you got exposed to 14 days. That is the reason why we have the quarantine period of 14 days, although that has now been revised to 10 days. But typically, infections occur anywhere from day 3 to day 5 after getting exposed to somebody who's COVID positive. But that varies though, up to 14 days.
All right, thank you. So the next question, once the vaccine is taken, is it still thought safest to continue wearing a mask?
Absolutely.
Yes, I thought that was actually really interesting. I heard that being talked about recently. And so we know that the vaccine definitely prevents people from getting sick from the virus, but there's still a lot to be learned about whether they can potentially still be a carrier and spread it to other people without symptoms. So that's a really interesting side topic. But yes, we definitely still recommend wearing masks after the vaccine until the herd immunity at some point will be attained.
So the next question is in regard to the booster. It says, are the booster and the initial vaccine dose the same as in, is the second dose the same substance as the first?
Yes.
Yes.
Yep. It's just a booster, just as your other booster shots for other conditions are. Mm-hmm.
All right. And then the next question, what if a person has IgA immune deficiency?
So the FDA, as well as the vaccine manufacturers, have not specifically commented on IgA immune deficiency. If we come across any literature, we will be glad to pass that along.
The next question, if someone is recovered from COVID, can they still be a carrier of the virus?
Yeah.
If they have recovered, they could test positive even though they've recovered, because sometimes there's still dead virus, and that's why the test comes up positive even after 14 days. But once the virus is dead, they can no longer pass it on to someone.
I just want to make a quick comment related to that. So typically, the amount of the maximum amount of virus that you typically harbor in your body starts to decline after about 6-7 days of having the infection. And that is why the current recommendation is to return to work on the 11th day post-infection. Majority of individuals, as long as they've not been in the ICU or not have been severely sick, they can return to work 10 days or on the 11th day post-COVID. Individuals who develop severe COVID infections, who end up in the ICU or on a ventilator, typically that period is extended from 10 days to up to 20 days or 21 days because the viral shedding probably is still occurring during that period of time. But for the most individuals, for the 98% who do okay, it is typically 10 days, and with the virus sort of trending down after about 7 days. So most infections people are not infectious at the end of the 10th day or the 11th day.
Thank you. So the next question is, will all OCHNs or would all OCHN employees be considered 1A? And I think that's probably leading to, would admin staff be considered in that group, or would it just be face-to-face, employees who are face-to-face?
I think that would be a question for the OCHN administration to answer. I think that would be something that you would have to look to your administrative staff to answer.
Yep, thank you. So the next question, what does the rollout look like beyond 1A? So would 1B, 1C, and 2 people get them from their health department or their primary doctor? Where would they expect to get their vaccination?
So the federal government has currently contracted with a number of pharmacies, including CVS, Walgreens, et cetera, to administer the vaccines for 2 groups. First of all, are the individuals who have the high attack rates, that is healthcare workers. And the second group is the group that has the highest death rate, and that is individuals in skilled nursing facilities. Once that group is vaccinated and immunized, they're going to move on to 1B, 1C. The CDC has plans to immunize this group, but they have not come up with definitive instructions as to how that needs to be done. I think MDHHS, which is our local Michigan Health and Human Services, is going to weigh in on that very soon. I think once they're done with this large cohort of individuals who have the high attack rates, who fall in that high attack rate and high death rate, then they will move on to the other groups, and we'll be able to provide more information to you probably within the next 3 to 4 weeks.
Thank you. So the next question, is there discussion for the future, in the future, that children will be required to be vaccinated with the COVID-19 vaccine to attend school in the same manner as the MMR?
That we don't know as yet, but we're looking for the school board to give us directions on that.
Yeah. And currently, the vaccine is approved for 16 and up, and the youngest I've seen in studies have been 12 years old and up. So, but yeah, we need some more information on how that will be and what will it be required.
Okay, so the next question again is about the rollout and the timeline for each phase. Is it subject to change, and how will people be notified or contacted when they are eligible?
Yeah, so that timeline continues to evolve. For example, we were initially told that we would all be eligible, at least the federally qualified health centers. They would be shipping us the Pfizer vaccine in the week of the 14th. That got moved around quite a bit. We have now been told that we're going to be getting the Moderna vaccine, and we were told the first 2 weeks of January. Now we're told it's probably going to be the last week of December, first week of January. So it keeps moving. Unfortunately, we do not have concrete answers for you at this time. I think the other question was, will people be contacted when eligible? We do not have that answer as well for you, unfortunately, but we will keep you updated.
So the next, I'm going to give you the next two questions together. I want to be respectful of your time, and I know we're approaching 1 o'clock. The first question is, are there any preservatives in the vaccine? And the second question is the vaccine recommended for women who are currently breastfeeding?
So I'm not sure what all preservatives are in the vaccine. I know that there's always concern about thimerosal. I do not believe that's in it, but I would have to look more in depth on that. As far as lactating patients, we know that so far it's not recommended in pregnant women just because we need more data, more people studied on that. And I would think that that holds true for those folks who are lactating. Maybe Dr. Austin or Dr. Hamadi can say more on that.
Yeah, all
so
sides of breast so
please go
far
ahead, Dr.
have
Austin.
said not to vaccinate pregnant patients. So at this point, I don't believe breastfeeding moms are included in the distribution right now of the vaccine. But so I think we just have to wait for the final data.
Yeah.
So the next two questions, one I think you addressed earlier, but it was, should people who are immune compromised take the vaccine? The other is, what is the technology for the other vaccines that are in the pipeline? Are they also mRNA?
So I know the AstraZeneca vaccine uses actual, if I'm not mistaken, like cold virus, not COVID, but cold virus to have that enter the cells. And what was the previous question? Oh, should immune compromised folks? So that depends on whether that immune condition is stable. Just like Dr. Austin said, the study included just under 200 folks with HIV, but they were stable and they did not have any adverse events to that vaccine.
All right, I think we're winding down now. So will the vaccine be effective with variant strains of the virus?
That's to be seen. Again, we haven't seen like mutations, thankfully, so far of COVID-19. So I think we'll have to wait and see.
So I'm going to try and get through these rather quickly so we can get everyone's questions in, but again, being mindful of your time. Are vaccine manufacturers testing children for safety at this time?
Yes, as low as 12 years old. I'm not aware of younger than that.
And then the next question, it must have been on your slide, and I'm not sure I'm going to answer it or pronounce it correctly. What is the side effects of Moderna arthralgias?
Yep,
What is this?
Yep, arthralgias. So that's just joint pains. And again, that was self-limited, joint pains for 24, 48 hours.
Any indication of when family members will be able to visit loved ones in long-term care facilities after they've received the vaccine?
We're hoping that after the second dose of the vaccine, the immunity level is pretty good, at least about 2 or 3 weeks post second dose. I think we should feel confident that there is a strong immune response. I think nursing homes will probably roll out some data related to the strength of the immunity that the nursing home residents develop after the second dose. We'll see something within the next 2 months. So 2 months after they receive the first dose or 1 month after they receive the second dose, we should have strong immunity in these participants, but data will tell us.
So the next questions are from Dr. Reed. She just asked if Dr. Ramos, if you would share your slides with us. I think we were going to ask that at a later time. I also, she wanted to thank you for your excellent presentation. And then to Dr. Austin, how do you as a physician approach the African American Black patients with vaccine hesitancy?
Yeah, that's a really difficult thing to do. And I think for me, I look at the data discuss facts with my patients. I think patients need to know that I plan to get the vaccine, and I think being an example to them, I think will hopefully help. And I think once they know that the steps weren't skipped when the vaccine was developed, I think they'll feel a little bit more confident. And the other thing I've been seeing in the Black community is the fact that the virus will change their DNA. And Dr. Ramos did discuss that already. It does not change their DNA. And I think once they're educated, I think I'll allow them to make that decision themselves. I won't force it on them, but I'll, discuss the benefits of it, because we've lost a lot of patients in our community due to COVID. And this will allow us to minimize the number of deaths amongst our population.
And Dr. Reed, sorry, you can definitely share that presentation. You can send that, Emily, to everyone. When you open it, it'll ask for a password, but just click the rightmost box and you don't have to enter a password, it opens.
All right, so the next question is regarding the distribution of the vaccine being coordinated in Oakland County. And so it's talking really about partnerships between OCHN, Honor Community Health, to make sure that the provider network and persons served have access to the vaccine. So I think we've all kind of established that partnership and collaboration will exist as the vaccine becomes available.
Yeah, we absolutely, we value our partnership with OCHN, and we will continue to have a dialogue with OCHN along with MDHHS regarding vaccine distribution. And if we could be one of the locations where, staff from OCHN or you consumers could receive the vaccine, we would definitely be very happy to do so.
All right, so the next question is actually from Dr. Reed again. It's specific to OCHN and tracking of the vaccines. And I think Dr. Lawson can probably address that question with Dr. Reed separately. And so I know we're approaching one or we're at one. So I want to make sure that we get through some of these other questions. There seems like there's just a few. One, can someone test positive for up to 3 months after?
Yes, you can definitely. We definitely know that there's some folks who will just continue to have that nasopharyngeal swab positive for months after. But again, if it's after that 10 to 14 days, you're likely not contagious.
And then I'm going to let this be the last question. So I heard that if you get the original Pfizer vaccine, that you cannot get the Moderna booster. Is this true?
Yes, I would probably say that's probably true. That hasn't been studied to get one vaccine from one company and boosted with the second. So I think we should plan to, whichever one you get first, then the booster should match.
Yes.
So I think I'm going to turn this over to Dr. Lawson now if she has any closing remarks that she would like to share. I know we went over our time just a little.
Yep, thank you. Just an extra thank you to Doctors Austin and Ramos and Hamadi. Your time and your information and your expertise is just valued beyond measure. So we really thank you for your partnership. We thank you for your time. And then thank you to all of our providers and all of our staff who took time to educate yourselves about this vaccine and this really important development in our ongoing fight towards normalcy and against COVID-19. So for anyone we don't see, we wish you the happiest of holiday seasons. Be well and be safe. Thank you, everybody, so very much.
Thank you very much. Happy holidays.
Thank you, everyone. Happy holidays.
Bye-bye.
Thank you, Dr. Hamad.
Yeah.